Good afternoon, everyone. We think it's 4 o'clock on most people's phones and devices, so we'll go with that. Welcome to the June 3rd Board of Douglas County Commissioners work session. For anybody who might be with us here in person, tuning in live or watching later, just a reminder that work sessions are for informational purposes only. It's an opportunity for presentation, for questions and discussion amongst the commission. And as always, we have a business meeting to follow at 5:30 p.m. where there is always a general public comment section for anybody who might have some thoughts they'd like to share with us as a follow-up then, or you're welcome to follow up in writing. And with that, I believe I'm kicking this over to Jill.
Good afternoon, commissioners. I'm going to hand it off to a really stellar team that I'm going to have introduce themselves in a minute. But just to cue things up, some changes that happened with our flexible housing pool program since it was first adopted. One of the biggest ones being that we shifted the supportive care provider for the program from the Burton Nash Community Mental Health Center to Mental Health America, the Heartland, which prompted some conversations and seeking of clarity from the commission earlier this year. So we wanted to make sure that we gave you all a chance to get a better understanding of the depth and breadth of the program and get an early sense of the impact that it's having. Because of the transition of the supportive services, we're still collecting initial data, but I think what you'll see today is compelling. And I hope that this gives you all a better sense of what are the key components of the program, what are we striving for, what's some of that initial data that we're collecting, and we'd love to get feedback from you all in terms of what other data would be helpful for you to understand the impact of this program. So I've got two presentations. Before I cue this up and invite our partners to come up, or invite Kristen to kick us off with the initial presentation, I'm going to let Simon start with introducing himself, and then we'll go down the table.
Thank you for that help. Simon Messmer, I'm the Vice President at Mental Health America of the Heartland.
Monica Casares, I'm a service coordinator with the DC Flex program.
Kristen Egan, Douglas County Housing and Human Services Program Manager.
Ani Nomula, I'm the data analyst for Douglas County.
And I'm going to have Kristen come up and walk us through a presentation online. Galal Obaid with the Lawrence Douglas County Housing Authorities online if questions come up specific to the Housing Authority. And then Sue Lewis is here with Mental Health America of the Heartland as well.
Hi, commissioners. I'm Kristen. Like I just said, I'm here to talk to you guys about flexible housing pools, kind of what they are in general, and then what we are doing here in Douglas County. There we go. Okay, so the first thing we did when we, not when we noticed, back in 2022, we partnered with the Corporation for Supportive Housing to do a needs assessment and figure out exactly what we need here. That data, that assessment confirmed a lot of things that we already know. Like we have a large number of chronically homeless folks that are cycling in and out of homelessness. So sometimes they do get housed, but then they return to homelessness. Very high rates of mental illness and substance use challenges, and that the current service provider network didn't have the capacity to provide enough support to clients with these high of needs within our community. And then you can see over there in the little box that the Corporation for Supportive Housing noted that 150 or more folks could benefit from supportive housing. That bottom number is from PIT 2025, which is the latest PIT data to be released. So we had 130 chronically homeless folks at that PIT count in January of 25. Best practices through HUD and SAMHSA is that the way that you treat or solve chronic homelessness is through permanent supportive housing. Permanent supportive housing is simply rent support, financial support, along with further housing, housing support along with actual supportive services. And again, that dedicated service capacity, the third bullet, is the most important piece here. And the piece that was missing, not only here in our community, but in a lot of communities, we were in a very common situation. PSH is traditionally funded through HUD, which is very slow and very rigid. So we saw the need and we do know the solution. CSH recommended some things for us to do. One, leverage what works. So we know that the housing authority here in our area is very efficient and very doing a really good job. So we partnered with them. We needed, according to the needs assessment, sustainable funding, which we got through Douglas County. And then they suggested that we target high needs populations. I listed some of those folks on that other side of the slide. All of this told us and told CSH that flexible housing pool would probably be a good solution, at least to the needs of some of these people. So I had never heard of flexible housing pools until, somewhat recently. So I suppose many people are in the same position. Flexible housing pools were built out of the same need that Douglas County saw, that there was a high need for PSH, but HUD funding is slow and rigid. So flexible housing pools started popping up to fill that gap in PSH. They consist of rental subsidies paid to the paid to the property owner on behalf of participants. So that's usually in a voucher form, although I'll get to later, we have a little flexibility there. Flexible housing pools have flexible resources and dedicated staff. The flexible resources, we'll get to that later as well. It is a huge benefit to this program, and we would not be as successful without the flexibility of the funding. And then, flexible housing pools also come with support services, and those need to be dedicated staff with a reasonable capacity, because the folks that are being housed in PSH, the folks that require PSH to stay housed, they do need varied levels of support, but they do need a lot of support. Okay, so in short, just what I went through here. Flexible housing pools fill the gap that PSH cannot fill because HUD is slow and rigid. We know it's the best practice. Most communities don't have it. And the people who need it are not able to successfully stay housed in traditional programs. So communities started building flexible housing models. They move faster, remove barriers, and serve people missed by traditional programs. So that's the background on flexible housing pools. And now I'm going to talk about what we've done here in Douglas County, which launched in March of 25. I believe we started with 20 to 22 units, households, and now it's moved up a little bit more because it's absorbed a HUD funded program. Okay, so as CSH suggested, we should integrate some things that we already have, supports we already have. We did that with Douglas County Housing Authority. And then we brought in Mental Health America of the Heartland for part of that as well. They do have, I think it's 25 years of maybe more, providing these services and this type of programming throughout Kansas and Missouri. So this is not new to them. They're a trusted partner and they know what they're doing. So we were happy to have them on board and dedicate staff to support the clients as much as they need. So let me back up to my slide. Douglas County provides the funding and coordination. Housing Authority, vouchers and structure. The vouchers are very similar to like a Section 8 or EHB voucher. And Mental Health America provides support and housing stabilization. And you'll see on all three of those, we're all three doing landlord engagement. So we do the landlord engagement lunches twice a year, but we also have, of course, Housing Authority is always reaching out to landlords. And in my position with the HSC, I am able to talk to a lot of landlords as well. But Mental Health America and TIF especially has been doing a really good job of recruiting landlords. I think we've doubled the number of landlords we have willing to work with us, and that's in a pretty short time. So I'm truly very encouraged that landlords are open. Okay. Who we serve. So people that qualify are those that are experiencing chronic homelessness here in Douglas County, high barriers through traditional housing, people that are willing to meet with staff, and people who do not qualify for HUD housing. So you guys likely know this, but HUD, I know I've said the word rigid, but they're rigid. And there's lots of people that don't qualify for HUD housing. That includes places like Del Mar, any housing authority vouchers, Babcock Place. If you don't meet the requirements of HUD, you are extremely, extremely limited. And that can come from an eviction from a housing authority. It can come from some of your justice involvement in the past. It's not that hard to be kind of banned from the HUD housing, but it's very hard to get housed without it. This local funding, if somebody is ready to be housed, maybe they've gone through the justice system and they're ready to be housed, but they cannot access like a voucher, they are a perfect person to serve through this voucher because we could bridge that until they get on to the Section 8 voucher. And just while I'm on that, I want everyone to understand that the goal of permanent supportive housing, sometimes people are going to need that for life, but a lot of times as they recover from homelessness, their support needs will decrease and our move on strategy is super important. So as soon as they get into a flexible housing pool unit, they have started their wait list on that Section 8 voucher. Hopefully, that's a long wait. So hopefully in those 2 to 4 years, we can provide support and they can recover so that in that wait list time, they are then able to move to a less supportive voucher. And then these vouchers to go somebody else in need.
Kristen, I have
Yes.
a question just as a point of clarification, because I'm kind of a nerd about the HUD regulatory chaos, we'll call it. To get somebody on a wait list, do they have to be deemed eligible first, or can they be put on a wait list and eligibility issues can be resolved throughout that time? I'm pretty sure I know the answer, but I'm just curious to know. So for the,
What do you think it is?
I think the answer is if they don't
That's
meet
what I think, too.
eligibility, they're not able
That's what I
to
think too.
have an application put on the list.
But
And I'm
we
getting
should
some
ask them all.
affirmative.
Yeah. So
Ed nods.
like this.
So then would there be case management planning or, supportive services that work to identify if it's possible to remove those barriers and be able to get them on the list?
Oh, sure. Yes, that would be a perfect goal for the Mental Health America team to work with their client on.
Thanks.
Yeah, sorry I interrupted you. You know I'm chatty. Okay. Let's see. Here we go. Did I skip one? Nope. Okay. So how do we find clients? All clients are required to have a CES assessment and score. Oh, oh, that's a long conversation. Coordinated entry system where you get a housing assessment and then you're on a list for community housing. HUD requires that, but we still use it because it's good practice. So once a client is assessed for housing, most of these folks have been assessed many times over the years, but we make sure they have a fresh assessment. Any case manager can refer them. It's a jot form that Monica made. Thank you for doing that. And then it asks a lot of good questions that I'll get to that part when we get to the challenges piece, but it's a referral form, making sure the person knows that they're being referred, they understand they have to meet with providers and that kind of thing. Then when we have an opening in the flexible housing pool, the referral committee will meet, look at those referrals, and pick which we think is the best fit for the program. At that time, the Mental Health America team will go talk to that client so they understand the full requirements of the program. Not everyone wants to meet with a service provider 1 day a week, 5 days a week. If they want to be housed without supports, this is not the program for them, and that's okay. It's not going to serve everyone, but we want to make sure that in this program, we are accepting clients that are willing to work with providers. Once somebody is in the flexible housing pool, officially accepted into the program, they'll start identifying units, but of course that's with a lot of help from the MHA staff. Mental Health America, the county, I'm sorry, I left the housing authority off that #1 bullet point, but they jointly recruit with us as well. We do offer different options, master lease, flex voucher for landlords. And like I said, that's going better than I expected. TIF is really good at it. Trauma-informed landlords, I'm talking about tenants to homeowners. They have probably housed half of our folks. It is extremely important, and we are so lucky to have trauma-informed landlords. Our clients are going to become symptomatic in their mental health, and lots of times that looks odd to neighbors or landlords. And it's very good to have somebody that understands that the team will come deal with the crisis and help avoid the crisis in the future. It's just better to have a trauma-informed landlord. But we also have affordable housing projects, which have been also very helpful to us. I kind of listed the ones that we have in town. It's not a complete list. I put Union at the Loop, New Hampshire Lofts, Penn Street Lofts. We have a lot of folks when New Hampshire Lofts opened up. We got a lot of folks moved from like a less desirable area to there. It was fantastic. They accept vouchers. It's easy. Same with Penn Street Lofts. We have not housed anyone at Union at the Loop, but they're on there because they're affordable housing.
Kristen.
Yeah.
Can you explain master leases?
Thank you so much for asking. It's the next slide. Okay, I'm going to do master leases first. So in the case that folks are not able to find a landlord that will approve them even with the voucher, which happens, we can offer that landlord a master lease in which in that case, Mental Health America holds the lease. And then basically the client is like a subtenant. I'm using that like subrecipient, but it is, I believe the landlords feel it is less risky. It can be paid upfront. And if the person exits the program, exits housing, they have an empty unit paid for, although we will fill it very quickly. So don't worry about that. Voucher is preferred though. Did I answer your question about master leases?
Yes.
Thank you. Vouchers are our preferred pathway because it builds rental history. And one of the things you need for a Section 8 voucher is to have rental history. So the sooner we can get somebody on a lease, the better. But it's okay if they need a master lease. If they need a master lease and they're a good tenant for a year, the landlord the next year very likely will offer them a lease, their own lease with their voucher. So it's just kind of a flexible backup option to have the master lease. Vouchers look just like Section 8 vouchers. They go through the things that the housing authority does, the briefing meeting, landlord educate or tenant education, that kind of thing. Okay, so that talks about the housing. Now let's talk about the support model. So with this, I'm talking mostly about Mental Health America. The support is frequent, flexible, and coordinated. By frequent, that will mean something different for every client. And it could mean something different for that client depending on the week or month, which kind of bleeds into the flexibility. As people's needs change, MHA is able to connect them with those different supports. When you are unhoused for a very long time and your basic needs are not being met, a lot of things go unnoticed, like your mental or physical health. And as folks are safe under a roof, a lot of new needs come up. And so when that happens, Mental Health America is able to refer them to different places, follow up with those referrals, coordinate things, and they're also able to change the frequency of their visits, as well as change like the housing support, what is it called? Thank you. Housing stabilization plan. Coordination is key. When we started doing this, we started support team meetings, which I'll talk about a little bit more on the next slide, but it's basically just providers coming together for a short 30-minute meeting and talking about what each person is working on with that client so that things are not duplicated, so that people feel like they are supported. We've got a great deal of feedback that's positive about the support team meetings in that it's opening up capacity at other agencies. So if somebody is working with Monica with MHA, but they also have a Burt Nash worker helping them with their mental health supports, it allows for Monica to focus on things like applying for disability, getting food stamps, and then it allows the other agency, like in this case, Burt Nash, can focus on the mental health needs. And we've gotten an enormous amount of positive feedback about creating more capacity by having those short meetings. Okay. Phases of support. This is just how you move through. So from unhoused to housed. You'll notice on each of these categories, referrals and support team meetings are in there. And that's because those needs change constantly for referrals, and the support team meetings, the cadence of those, the frequency of that can change. Some clients need 1 or 2, some clients need like 2 a week. So it just depends on their needs at that time. But those referrals and support team meetings under each one. In the housing search support, MHA will help the client understand the program, understand the expectations. They will help them apply skill building. By that, I mean, how do you speak to a landlord? How do you present? Getting ready to be a good tenant, learning about that. Move-in support, helping the folks understand their lease and the unit and the program expectations. We do have a move-in guide. It's when you've been on house for a really long time, you forget, or maybe you never knew how to use things like a dishwasher or a thermostat. And it's very helpful for landlords if we help the client understand how to use their unit. We did have a client call in a maintenance request for a thermostat. She just didn't know how to use it. Of course, we went over there and helped her figure it out, but it's just little things like that you don't think of. And then along with that, addressing guests. Having guests over and having too many belongings is common. So we try to talk about that from housing search on down. And then housing support, once they're in there, helping them develop a routine, connection to supports and community. There's a lot of isolation with moving indoors. They lose their community, their friends, their family, people that have kept them alive. They're also very busy when they're unhoused. Boop. Okay. What's working? Coordination, the support team meetings, shared housing plan, flexibility. This is really important. Like, I'll give you a really quick example. We had somebody that was housed in a tenants to homeowners tiny home. That was too isolating for him. He was not ready to be housed alone. The flexibility of this voucher allowed us to take him to a tenants to homeowners transitional unit where he's surrounded by some of his community members. And it really did wonders for him. And then the capacity is just like the main thing that we didn't have and that we do now. It takes a lot of work to keep folks housed out of chronic homelessness. And if you have caseloads of 50, you're just not going to be successful. You just won't. Challenges, landlords, curious but cautious. We're continuing to engage. The level of need. So some folks, we have a couple in the program right now that need a higher level of care. We just need to accept that higher level of care does not exist here. That's not a burn on Douglas County. It doesn't exist really anywhere, but people with higher levels of need, if you need a nursing facility, this is not the program for you. Client engagement can vary quite a bit, but we're hoping to kind of nip that in the bud with the new referral form that asks about engagement and being more upfront with what the program requires. And then the isolation, we're trying to work on through community connections to existing meetings and groups. And there's also a new group we started in conjunction with Cheryl Sanders, who you may remember worked at LCS. And it's been a really fun group for flexible housing pool folks to get together and do fun things. That's it.
I do have a quick question
go ahead.
regarding the individuals that do need a higher level of care. What does happen for individuals that do need a higher level of care?
It's a really complicated process that includes assessments, skilled nursing facilities, nursing homes for mental health and FMH. It takes a lot of coordination between healthcare providers and those facilities. It is slow and it often falls through.
I also think, Simon and Monica can talk a little bit, maybe real quick, about just observations with folks that have been recently observed of having a higher level of care that, there's active problem solving that goes on in terms of, is this workable? But it's a lot of collaboration. It's a lot of coordination.
And nursing facilities are not required to accept you.
Okay. And so when that does fall through, what are we doing when it does fall through? So I'm kind of curious what that looks like. What is our mitigation plan, our contingency plan? What's happening to the individuals, to our community partners? How are we seeking
Well,
to move forward?
So, correct me if I'm wrong. I don't know that we've truly had anybody completely fall out. I'm only aware of one person who had to leave the program. We've stayed engaged with that person. We told her that we would follow up with her in 3 months to see if she's in a better place. And more, in this case, it's somebody who's a little less willing to engage with all the resources that you all have made available already. But we're going to stay connected with her as best we can and invite her back to the program after she's given it some thought and maybe wants to come back is in a better place. The person that is on my mind, if I told you too many details about her, I think you'd probably know who she is. Her issues are so profound and she appears to be so visible in the community that I think people could know who she is. Her issues are social, they are behavioral health, they are physical health. These folks are working really, really hard to get her access to all the benefits that she's entitled to that she hasn't had a chance to access before. We are hopeful that benefits like that will keep her in the program and in the community. She needs things like personal care, probably at least 8 hours a day. And there's no, to the best of my knowledge, there's no organization maybe in the state, maybe in the country that could provide that level of care without some kind of payer source. And we think that Medicaid can be that payer source.
And on June 24th, just a little teaser, Bob is actively curating a conversation with like, what are the gaps in our crisis in this system of care, and the challenges that this team is facing with individuals like Simon mentioned. That's going to be a component of it. But I would say, if we are operationalizing housing first principles, which we're not obligated to do, but we do think about those as a best practice, that means that we're being very clear with the participants about what's expected of them as being a part of the program. But it's often giving first, second, third chances. But at the end of the day, like the team said, you have to meet with somebody. You have, to the greatest extent possible, uphold the tenets of your lease, or if you're under a master lease agreement, you have a tenant occupancy agreement. You have to maintain the tenets of that. And if you can't do that, there is a thoughtful way of transitioning folks out of the program. And best intent are to find a landing spot for folks at the Lawrence Community Shelter or somewhere else. But at the end of the day, self-determination rules the day. And that is a significant challenge with this population, making sure that we're offering as many supports as possible, but the staff can only do so much. It's not 24/7 care.
And then for the individual that you mentioned that you're seeking to redetermine or become eligible, do we have community partners that are supporting that individual?
We do. So I think that this person ended up, I'm going to look at you, Monica, I'm sorry, because you do the real work. You do the hard work. I think that they are connected with staff at Lawrence Community Shelter and then also the homeless outreach team.
they're connected with Heartland RADAC, LCS, MHAH, Burt Nash Path, and visiting nurses and HRT.
Thank you.
We can do lots more discussion. I want to make sure, I wanted to make sure we have time for Ani to dig into some of the data, just to give you all a sense of what kind of impact at a population level that we're striving for. We've talked about like the client level impact, but when we look at population level impact, our big goals are to impact chronic homelessness, but we also know that the chronically homeless population often some of the symptoms of that ongoing chronic homelessness is an over-reliance on emergency services, whether that's emergency shelter, EMS services, hospital. So I'm going to hand it off to Ani, our human services data analyst, to walk through some initial analysis of the impact. Oh, he's got
So hi everyone, my name is Ani, and today I'm going to be walking you through some analysis I did on the flexible housing pool clients. So I looked at 24 participants in total, and 18 of them are currently being housed, and they have dates ranging from March of 2024 to May of 2026. So before we look at the FHP population, I think it's good to have a look at the broader overall homeless population. So this is some data that I pulled from HMIS with the help of the Kansas Statewide Homeless Coalition. And as you can see here, uh, this is a population that is already at risk of not self-resolving. And FHP clients are being pulled from this population and are within this population, they are high utilizers of emergency services. So on the next slide, you'll see how they compare to the overall population. And you can see that they come in with more disabilities, and on average, they are older than the system-wide population. So people like that tend to be in more need of services, and they tend to be higher utilizers. So an example of one of those services they are pouring into is LCS. So this is an extract of the LCS data set, and you can see how the services are performing as of now. They tend to be pretty consistent, at least the continuous stay and the village. They aren't self-resolving. Night by night definitely isn't self-resolving. And you can see some patterns within that where it is peaking, especially at the beginning of the year. So how do FHP clients fit into that? So as you can see from this slide, they're taking up a lot of days in LCS. Out of the 14, from the 14 out of the 18 FHP clients that we matched, they're taking 1,796 overall. And with the FHP program, after being housed, that automatically results in no more LCS stays. Now we take a look at their emergency contacts overall over the 18 clients. They have different windows of usage, especially since some of them were recently housed. So in the next slide, we take a look at 10 of them which have 9+ months of data post-housing.
I had a question on your last slide.
Yeah.
The number of service calls, is that for the 26-month period, or is that what period of time are those? I see one there with 70 calls. How long of a period of time did that take?
Yeah, so the period could range from either a couple months to close to a decade of time for including all of those counts. So that's why in the next slide, I limit it to a 730-day period window. And I look at those that only have a longer period of housing history. And we can see that 7 out of 10 of them are using emergency services less. 3 of them, it's iffy, especially, for example, client 11. So clients like that might need some more attention and more support in what they're dealing with. They might need some access to different services on top of FHP. So now we look at the emergency services overall and how they've lessened after the introduction of FHP. And you can see even for these services, they're going down quite a bit across that 10 client cohort. Yeah, and these are some conservative estimates of how much we'd be saving in terms of the different services being used. So this was collected based on work that our previous data analyst did. And then I got updated numbers from all the different emergency services around the county. And I also estimated some price differences on my own. But the methodology for that I've submitted as well. So you all can have a look at that after the meeting if you'd like.
Can I ask a question real quick?
Sure.
So EMS and ambulance wasn't included. Did you estimate that? That's my question.
Yes, so for the EMS and ambulance data, I did get the number of people who were using those services, but the updated cost, I wasn't able to get it as of now. They didn't provide that to me in time, so I can work on getting that number later on.
Thank you for this. And since you're looking at healthcare costs and also since we're evaluating the amount of funding that the county is also contributing, I know that earlier we took a look at the amount of funding that the county is contributing to the housing authority. And then we saw the master lease agreements on the slide as well. Now, it did not indicate funding for the master lease agreements.
That's Douglas County as well.
Okay, that's what I thought. And so are you also looking at per member per month, or is there a way to understand, for example, per member per month and the cost associated for the members that we're supporting?
When you're saying month per month,
Per member, so I'm thinking of, or we could say per client per month.
client per month.
Yeah, I mean, that would be really easy for us to get based off of what we allocate to the program. So that's a good follow-up item that we'll get for you.
Yeah, I could include it in future analysis,
Okay,
definitely.
thank you. I appreciate that. And then any particular savings as it relates to per client per month as you're comparing the various metrics that you have pulled together here so that we can understand per client per month the savings across the board for the various metrics. And so if we're having savings in our law enforcement or how we're stabilizing the various departments, the various support services that are supporting our populations, if we could then see per client per month the benefits, the cost to benefit, or the return on health, the return on investment that we're seeing across the board, across our system, the system changes that we're seeing, I think that would be beneficial to the commission so that we can understand the system changes, the stabilization that we're seeing.
Yeah, I think the thing to note as of now is we already have such a small client pool that we're looking at, and they also have different windows of timing associated with them. Like some of them only have a few months of history, some of them have longer than that. So even with the granular cost estimates that you're asking for, I think the results would be skewed at this moment of time, but it would still be helpful to look at. So I could definitely try putting that in there. Yeah.
Thank you. I appreciate it. And then as we move forward, at least you have a baseline for us to look at. And then moving forward, maybe we could then take a look at those trends.
Sure.
Thank you.
Ani, I do think it's important to include the ambulance calls in that. That's a most frequently used.
Oh, yeah. And as we just saw, we go back, that's the one that has a lot of reduction. Yeah.
I think just putting a dollar.
The dollar
to it,
amount,
that, you know, that I was missing that too on the next slide because, and that's something that it's obviously significant in that chart. And then a significant investment of the county budget.
Rides aren't cheap, that's for sure.
Yeah, and I think it'd just be good to visit. We've gotten a lot of data in the past from Ellen, from the fire department about, so I was surprised that they didn't have it for us. I mean, they seemed really good at being able to give us that data. So that was sort of curious to me. That's why I was asking.
If you remember, it's not technically Ani's predecessor, but when Matt Cravens was here, he did the analysis on the cost of homelessness. That did have a number in there for ambulance. So he's looking at that same document and he'll update it. That's the goal, is just from a timing perspective, we just didn't, those numbers have gone, the inflationary impact from when Matt did that first report, I think it was 2022. I forget when he originally published it. Those numbers were in there. So yeah, we'll update that, and Ani will update it, and we'll get you all a fresh copy of it. Yeah.
Yep, so this is a look at how law enforcement has played a role in the FHP population. So you can see that they contribute quite a bit to the overall contacts. A lot of them are within Douglas County. I'd say the majority of them, and then the rest are there some parole or some out-of-county interaction. And the majority of them cluster within 2023 to 2025. So when we look at the bookings after housing, they also tend to fall down sharply, except for one client, client 13, who seems to be an outlier. So that's somebody to take a closer look at and see if they might need any more forms of assistance.
Can I make just interject a point here, just based on my experience in crisis work and housing and criminal justice space? Sometimes an outcome, you know, Kristen, you made a good point earlier about how some challenges get either resolved quite quickly or gradually once somebody is housed, but then other challenges present themselves. Sometimes one of those challenges is having to resolve all of your legal issues that you have not been present for, and that can be a significant and a productive goal to resolve, to go serve. Sometimes it's, I hate this phrase, but I'm going to use it because people in the world know what it means, to go resolve like quick dip sentences from different municipal courts around a region where they just haven't been appearing, and they might get ordered to 24 hours or 48 hours, a weekend, or a certain amount of days to resolve something. So sometimes that's the reality. I just want to be clear that it's not, I do not believe that to be indicative of new, current, contemporary criminal behavior in the community that's resulting in new charges or jail bookings. It's much more nuanced than that.
Okay, so now we take a look at some folks who haven't been housed yet, but are in the program. So you can see how their overall contacts are, and that just represents an ongoing system cost, which potentially could be lessened by them being housed. Yep, and coming closer to the conclusion, so 10 out of 18 have 9+ months of post-housing data, and they show an overall reduction of 59% in emergency contacts. Ambulance and emergency department contacts have the clearest reductions, and jail bookings also have a reduction. LCS isn't self-resolving. All 18 people are placed into stable rental housing with ongoing subsidy. caveats, some of them have been recently placed, so their story is still ongoing. When I say no control group, that means we didn't look at people who applied for FHP and then weren't accepted and then track their history onwards. So that would have been a good comparison to look at and see if they had self-resolved or not. Some folks have, well, client two in particular has no pre-housing contacts. So that type of observance represents a lack of data availability, but not utilization. Client 13 continues jail bookings. We're still waiting on some cost estimates from the fire department. So our next steps would be to get that information, maybe have a case review for client 13 and revisit all of this in a couple months down the line and see what more findings we can gather. Also, lastly, there was some behavioral health court involvement, some records that I saw in there. So it'd be good if we could look at the court data as well and put that into the analysis.
Thank you. I have a quick question for slide 31. If we could just back up to the 6 individuals in the housing pipeline, the not yet housed. Would love to know what the total cost is for the not yet housed, or even for the 6 individuals individually. Because if those 6 individuals do get housed and move into the pipeline, that at least provides us a baseline for the 6 individuals that are not yet housed so that we can understand what the cost is for housing them and or what the reduction is in the housing of those individuals as they move into the pipeline and they do get housed.
Sure.
Okay. All right. Thank you.
Yep. Thank you all.
I just want to say thank you and great work.
Thank you. Ani, there you go. Thank you. Appreciate you bringing the camera view back up. Just a quick reminder, commissioners, that we also have Galal from the Housing Authority online with us as another community partner. So I'll just open the floor to any other questions that have populated for commissioners.
Do we have any flexible housing units that are open and not yet filled?
Yes. Yes, go ahead.
Yes, we do. We've got a couple of openings from transitioning folks to other places. And then we just wrapped up a new lease today that I hope will maybe be able to house a family, but currently empty.
Because you have a few under master lease.
Under master lease. Yep. And there are a couple openings. By openings, I mean we've got 6 people in the pipeline, so they'll fill quickly. But
I also think that just because MHAH is a newer organization still to the community, they're ramping up in the community, they're building their staff. The staff is getting situated. We've done a slow roll into the program. So there's 18 folks that are in there now. And so it's, you can't do overnight 32 households. So it's funded for 32 households. And if I did just straight math on the total funding for the program, and for 32 households, it's $28,781 per person is the way that it is per household, is the way that the budget is set up. So once we have, more information like Ani was talking about, we can come up with a good formula for a cost savings, even if it's a community cost savings. And we don't even have law enforcement calls in there either. So that's like a whole other set of data that, we can continue to chip away at. The data that's in my RC continues to get better all the time. But this is just kind of scratching the surface.
Question, I think you just answered it because you mentioned a family. Simon, sorry, I was just pointing at you.
that's fine.
So we do have both individuals and families who are housed. Great.
Yep.
I had a question about the success stories at the Friday meeting that many of us attended. Do their needs lessen? I mean, those individuals seem to be pretty with it. So I would guess the time you
Oh.
need to spend with them is
Uh-huh.
quite a bit less than some of the other people.
I think that it's too bad, and maybe it's a good thing that you hadn't met some of these folks 2 years ago. I think that you would have met very, very, very different people. I don't want to gild the lily too much, right? But it makes a huge difference when folks just have a stable, safe place to go, and they've got service providers that they can trust and build relationships with. And I genuinely believe that that's what you saw.
Monica.
I was
you
going
might
to say,
be the-
Monica,
You might be the one
yeah.
that knew them when prior. Get really
Yeah.
close.
Yeah, so the needs definitely do lessen over time, but we still meet with clients once a week and as needed, depending on what's going on in their lives. Yeah.
Monica, can you talk a little bit about what does success look like to you with some of these clients that you've observed in your work in the community over the years?
I think success is seeing them reintegrate with their families, with their communities, finding new friends, like, hobbies, kind of more than just survival, like moving past just surviving every day. That's the success I see with many of our clients.
I did ask Monica about those people you were talking about, because I did not know them when they were unhoused, and I was also very impressed by them. I think it was quite different 2 years ago. I look forward to seeing the folks that we've housed recently in a couple of years.
Oh yeah, and Galal has his hand raised. Go ahead and unmute Galal if you want to offer anything.
Thank you. I just wanted to address a couple of points. Kristen had mentioned that LDCHA requires 3 years of rental history. We actually require 3 years of residential history. So it doesn't necessarily need to be a rental process. So the master releases would take into, that would be considered 1 year of residency. So we look at 3 years of residency, and we're looking to reduce that to 2 years to match our transitional program, since those programs, after 24 months, they typically transfer to a permanent voucher if they're successful. That's being explored, and if we can get it through, would take effect in 2027. And then I wanted to address the question about if they can get on the wait list. Part of their interaction initially with the housing authority and getting a voucher is that they're submitting an application to LDCHA, and we're able to place them on wait lists. Because the wait list can be 2 to 4 years, we're hoping that their time in the permanent supportive or with the flex voucher or flex program could essentially lead up to the point of where they're coming off of the wait list. They get to leave the flex program and get a voucher through our programs. But yeah, I wanted to make those 2 points.
Thanks, Galal. It's very helpful. One of the things you asked is what kind of data we would like to see in the future. And I'm curious, it's completely understandable to me that when someone has been homeless or been in the shelter, they may require a high level of services and maybe even things we didn't even think about once they get in some supportive housing. How might we look at it over time to see the cost of that service at move-in, the cost of the service when they're searching, the cost of the service as they move in? And it may be too short in this data set, but I'm interested to see over time how we might see progress. And I would expect, I'm not trying to answer my own question here, but I would expect over time that it would be different for different individuals because it's so unique. But do you have thoughts on how to, you've done this in other places, so I'm interested, places you've been longer?
Oh no, that's a really good question. And it's really tough to get to really good cost analysis. It really is. It's just true because there's so many systems that intersect and they all measure everything differently, from like the amount of time spent to how you count a dollar. It varies a lot. The thing that I would be curious to know more about, personally anyway, is how, if there's a way to tease apart sort of behavioral health things from some physical health things. One of the things that I'm concerned about when I see that average age of 49 years old is that I think that we've got a much older, we've got an aging houseless population and a much older houseless population than we had 20 years ago. And I think that we're going to see more and more chronic health conditions that are outside of anything that the behavioral health system, as we understand it today, can really address well and efficiently and cost effectively. So I'd like to see more info on the impact of those health conditions.
Yeah, thank you for that. And that makes me think, you talked about baselines, the older you get, the higher your healthcare cost, right? So are we overly inflating that healthcare cost down the line? And just a comment, like I love these conversations because in my head, though it wasn't, you're not providing all the services, right? You are case management and you're connecting a system together. I think that's really important when we look at data the work here is great because you've pulled so many groups together, and yet I'm cranky because we don't have even more, right? So I think it is really tricky to get to. We'd love to have a perfect world where data told us what we needed to know.
Yeah, and I worked really hard to use the word service coordinators for my folks, because really what I think that they do is they try to coordinate both across people and across systems, because it is so complex. Human beings are incredibly complicated, whether they are houseless or not. Right?
And the case management should be happening with one of the community partner agencies. I mean, if it gets a little too close to intensive case management sometimes, and we're certainly seeing that with a couple of folks. And that's where we have to problem solve and is this a higher level? And we've got to figure out plan B. We're really lucky that MHAH has recruited some really compassionate, talented staff. Tiff is here, Monica's here, of course, and Mary isn't here, but we want to make sure that we're managing the capacity of that staff and their burnout, and that we are bringing all the partners together that do have the case management responsibility on their plate. That is their job. But if you quantified, Heartland Health, their community health workers have touched all these folks at some point. They know them as well. Those staff at Burt Nash, the hospital EMS, Mobile Integrated Health Team, they're all very familiar with these folks. So I think Ani's gotten us close to trying to come up with that cost estimate, but there's a lot more work that we can do. You've asked before previously just how we're tracking outcomes. We gave you some outcomes initially that from our emergency utilization system, but just, what we compel from our agency partners that have a community partner agreement. This is just an early view of what we've gotten from Mental Health America of the Heartland. We've got a nice handy dandy online report that our team at Douglas County IT has created for us to start tracking all this stuff online, so that in the future maybe you'll have a dashboard to be able to look at all this. But just to give you a sense of what the first couple quarters have looked like, the number of people that they have actively worked with. You can see that number, the housing durations, average number of days that folks have been housed in this program. And one caveat I wanted to say is, while we launched the flexible housing pool program in March of 2025, this data encompasses that permanent supportive housing project that I came to you all a couple weeks ago to accept the HUD grant. You wanted information to make sure that we're also reflecting how those folks are being served. So we went back to March 2024, and a lot of those folks that were in the program in March 2024 are still in the program today. They've transitioned over and they're reflected in this data. So when you look at folks that have been housed for over a year, a lot of those folks have been housed through that initial permanent supportive housing program. But then just a snapshot of what are some of the activities that Monica and Tiff and team are involved in. Many management, employment, vocational supports, ADLs, those average daily living skills, which are critical. And then just looking, what's the amount of activities? How many instances of work has been done in terms of those mainstream benefits assistance? How many supportive services check-ins? It's a lot. If you look at some people might need a couple times a week, some people might need it every day, depending on the intensity. And that's what the staffs are doing. Those referrals to physical health, these are all indicators of recovery and stabilization. But then, of course, when you look at page 2, we're also tracking, those crisis and behavioral health services that are utilized in that time period, which is normal. As folks stabilize, they're still going to experience crisis. So when we look at, MRT instances, EMS, law enforcement, and these numbers are a little skewed by one individual, as we footnote here. And then just some additional information about how many folks transitioned from those master leases to the flex voucher, how many moved on to a mainstream voucher, how many were not successful in the program and exited to homelessness. And we do have on there as a placeholder. We know that there will be deaths in this program at some point. It's just a reality. And we, when we talk about that aging population, we mean what we say when we say this is permanent supportive housing. Folks can live in these units if they need that support as long as possible. So that's just one indicator we're looking at. And then you can just see some of at the very bottom, we're just starting this work. And this relies on the MHAH staff building rapport and trust with the clients in the program. But just what's the client satisfaction? So these are just a few of them, that they're eating healthy, they're feeling good, they feel safe. That's a huge indicator. And then they're feeling supported. So just an initial indicator of how are the clients feeling? What's their satisfaction with the program? So we just started on this. We'll give you more information, but this is also something that MHAH is keeping track of.
Thanks, Jill. Appreciate this. And that reminded me, I came in here with one sort of specific question about, we spent a lot of time having questions about or talking about like the complex systems and the varied systems to navigate benefits and all these rigid regulatory environments and whatnot. I'm also curious about some of the, I guess for lack of a better phrase, simpler barriers, like transportation is one that is huge in so many ways. Can you all speak to a little bit about like how it is that your team resolves for that, specifically when there are no good transportation options for that individual, be it because of mobility or distance or other reasons?
I know that Monica likes to talk about the bus system, and I'm hoping that she'll talk about that a little bit.
So recently we just had like a training on the bus routes where, the team, we were followed around by someone and they showed us how to go through the bus map and how to take the bus, get on the bus to help clients. And we also rely heavily on the T-Lift, the on-demand service. Senior Resource Center has transportation too, but it's definitely a huge barrier.
Yeah, thank you. I think I'm interested to know as time goes on if there are, you mentioned kind of sort of all the key options, Independence Inc., another one that sometimes is workable for folks, but they all have their limitations. They all are restrictive or less accessible in one way or another. I think T-Lift is probably, it's as accessible as I've ever seen it in my decades in the industry, but I always think there's room for improvement. So I really welcome, like, transportation is such a key thing, and it's some doctors' offices have really rigid, like, guidelines around if you're 10 minutes late, or if you're 5 minutes late some places, that your appointment is canceled. And if you have a number of canceled appointments, you can't come back to that provider, so it's such a domino effect because you can't get a ride somewhere, or because you missed the bus, or because you didn't request a T-Lift, in enough time. So I know it's very depending on what the person's needs are and whatnot, but I really welcome any specific ideas and feedback about that. The county doesn't necessarily navigate transportation, but it is something that I'm interested in, and how we can talk to our partners, especially if you're seeing it regionally, beyond the city limits of Lawrence and the resources that are offered through Lawrence Transit.
This might be too specific, but one of the on-demand services, it serves the weekend and it's $3. And my client was able to get $3 to take the bus to get glasses, and they needed a card. So she needed to have like a debit card, and she doesn't have one. She might not have one anytime soon. And it's just like, man, if they could just take those $3 from her, it would have been, we figured it out for her, but that would have made a huge difference.
I really appreciate that. Is a perfect illustration. Like, most people don't think it's that hard to either come up with $3, but for some people it is. That's one point to make. And if you do have $3, you probably have it in cash, and you might assume that a transportation provider would take your cash, but that's not the world that we're living in these days. And so I think that's a perfect illustration of how do we resolve for when that comes up. Is there sort of a prepaid card that is on demand to be used for those things, or for Uber and Lyft and stuff? So thank you.
I think that's when we say flexible, let's lean into the flexibility. Let's iterate and experiment with things like that. And when the staff brings ideas like that, like, let's give it a try. let's give it a try. Because that's what the $880 that is plugged into the budget for each of these individuals, those are flexible dollars for, could be a prepaid card for the T-lift.
I had a question. Maybe you don't evaluate this, but do you think any of these people are employable?
Yeah, some of them are employable. There are some, I am not a vocation expert.
Yeah.
That right up front. But I talk to folks, I look at folks, and I think that some of them absolutely are. In fact, we've got somebody now who's getting ready to start a small business, and I don't want to speak. I know most things because I approve expenses, or I talk to Kristen about expenses. And one of the things that we've approved recently is supplies for somebody to start a business and to get their professional certification up to date. So
And
I know it's happening.
yeah, and that was how he made his living prior to becoming homeless, and that will get him back to work. And he's very proud, and it's such a perfect example of how those funds can be used. It's just really helpful.
Well, and I see that you're providing employment and vocational support too. Okay, so on to Commissioner Dorsey's question, how many are employed?
I don't know how many are employed. The goal is always to get them income, be it disability or earned income. So those are just different pathways that the coordinators can take. If it's a disability thing, we'll help them with that. But if it's an employment thing, that's when voc rehab and that kind of thing would come into play. But one of the main goals is, yes, to get everyone income.
Okay, all right. And so do you know how many are either enrolled in
I don't. So
vocational?
one of the notes I wanted to make is that we aren't even tracking employment. I noticed when I went to do the outcomes report, we're only tracking access to mainstream benefits, by which we mean supplemental income. So it's something we will start to track and do a better job of.
Okay,
Most recently enrolled client, she's a mother, she has children in the household, and she works full-time.
okay,
She's participating in the Cardinal House Network program too.
great. Okay. So you will be tracking employment moving forward and then maybe even vocational programs or
Yes.
certificates
Yep.
potentially? Okay, thank you.
Commissioners, I wanted to just give you all just one thing that we're seeing, when we mentioned folks that are trending into that 50, that are in that 55 plus category, and folks with these higher needs. Just looking ahead, and I think Bob's going to talk about this in a couple weeks, but one thing that we're experimenting with one of the individuals, but I think there's other individuals that this will apply to this program in the future, is we've got an interesting partnership conversation happening between two agencies that have received funding from Douglas County for a long time, Trinity and Home Care and Visiting Nurses Association, just to understand, is there an opportunity to collaborate with those organizations for individuals that need, whether it's short-term or longer-term nursing supports to recover from an operation, an illness, and that VNA can traditionally do, or those personal care supports that the Mental Health America team should not be doing. And we're seeing that with one or two folks. And so when we think about what is the long-term trajectory of this program and the constituents it serves, that 55 plus population is, I think, increasingly going to get our attention. And one of the things that when we think about addressing barriers like transportation, it's co-location of services, co-location of staff in buildings, things like that. So that's long-term. Some of us got to go to a Housing First conference in San Francisco a couple weeks ago and hear about some of the projects that are supporting this population, because in every community, that 55 plus population is what is really, and folks with high acuities, it's eating everybody's lunch in every community. So when we think about what are the solutions, we're experimenting with some trusted Douglas County partner agencies that I'm excited to see what we can share with you all in the future.
Great. Thank you, Jill. Thank you, everybody, for being here. Commissioners, any last questions?
Just Jill, I'd encourage you to add LMH to your list of who you're engaging. I mean, there's a significant savings here for LMH, for the emergency department.
Friday afternoon, we're talking to them.
Good, excellent. Glad to hear that. And I know we're out of time, but we do need to recognize, you know, there is a ton to celebrate in this report here, and we're asking a lot of questions. We asked for a lot of data, and Ani, great job. I mean, it is much easier to understand the way you've looked at a cohort group, to understand those impacts, and pulling out that some of our individuals are high utilizers of our systems. We've heard that here before, but to actually be able to see it, but not see it as a person we can identify, I think is some really nice work. Staff, I just want to thank you for bringing mental health, I got to get the words right, America of the Heartland on, because I think we were at a time when our provider wasn't working great. And some of the data that you're giving here is really showing that we're making a huge difference. It's a small population, but it's a high needs, very expensive population. And they're part of our community, and we need to welcome them and give them the supports they need. So I just wanted to say thank you for your work on that.
Well stated, Commissioner Kelly. I concur, and this is what investing in human infrastructure looks like, and this is what the power of community can do for people. So thank you all for helping folks move from surviving to thriving, and I'm excited to see how it progresses and how the data tells us more stories as we get more and more years under our belt. So great work, everybody. With that, we are recessed until our 5:30 business meeting.